spent the last few weeks talking work requirements for safety net programs, and it's all been leading up to this: work requirements for Medicaid. By looking at the EITC and TANF, we've learned some things. Can these lessons inform decisions about whether to implement work requirements for Medicaid? And if so, how? That's the topic of this week's Healthcare Triage. You may remember from 2 weeks ago that incentivizing work, like with the EITC, does appear to reduce poverty. Economists of all stripes seem to agree. It's therefore not irrational to think that there might be some other benefit to incentivizing work with other programs. There are also some aspects of TANF that would tend to support this notion. Employment did seem to go up temporarily after work requirements and other reforms were enacted in TANF. It's also true that fewer families in poverty receive TANF cash assistance. In many people's eyes, these are both good things. And if those are your main foci, then it's likely you'd support the idea of implementing work requirements further. But there are other lessons from TANF, including the fact that job training, education, and counseling may be important in enabling people to comply with work requirements. Poverty didn't seem to be affected much, absent the effects of the federal EITC expansion that happened at the same time as TANF reforms. If you're mainly interested in poverty reduction, then work requirements in these programs don't get the job done. It's important to remember that in all of these cases, even though there were medical exemptions in TANF, those that had major health barriers and who should have been exempt but were not often didn't find work. Why is this important? Because a disproportionately high number of people on Medicaid have major health barriers. The Kaiser Family Foundation has looked into this. An analysis from spring of 2017 found that almost 80% of adults on Medicaid are from working families. Almost 60% of people on Medicaid are working themselves, and that's, of course, without any work requirements. Many Americans, even if they're employed, have wages so low that they still qualify for Medicaid because they earn less than 138% of the poverty line. This assumes, of course, that those states accepted the Medicaid expansion. In states that haven't expanded Medicaid, many adults who work are very, very poor, but still can't get Medicaid. Of the minority of Medicaid recipients who don't work, more than a third can't because they're disabled or sick. Another 28% are primarily responsible for caring for others in their families who are young or sick and therefore can't work. Another 18% are full-time students, 8% are looking for work but can't find it, and 8% are retired. Therefore, if you're doing the math, that leaves about 3% of the adult Medicaid population who we could define as able-bodied yet choose not to work. Let's look forward, not backward, and examine a specific state. The Urban Institute looked at those who might be affected by Kentucky's work requirements. There were about 653,000 non-elderly adults on Medicaid in 2016. About 24% of them are disabled or receive SSI and can't work. These enrollees will not be affected by the work requirements. Another 26% are students or caretakers of children or disabled household members and are therefore likely exempt from work requirements in Kentucky. Another 25% are not likely to qualify for a student or caretaker exemption, but are working. This leaves about 25% who could be subject to the work requirements, but are not working. Of those, 44% are over age 50. 38% have at least one serious health limitation. But the concerning thing is that 74% either don't have a car or access to the internet, have not completed high school, have a serious health limitation, or live with someone who does, which could make it very hard to work consistently. Some of these people could qualify for an exemption because, for example, they're medically frail or pregnant, but they'd have to know about these exemptions and be able to successfully obtain them. Now, some would argue that the fact that so few people be affected is a reason to do this. It won't be terribly disruptive, but that assumes that it will be easy to work through the administrative burdens of work requirements. There's no reason to believe that this is the case. In fact, there's evidence that many people who will qualify for Medicaid and a work requirement exemption might fail to get it because they will be unable or have great difficulty in meeting the paperwork burden. A recent Urban Institute analysis found that about 1/3 of those working are either not working enough or may not work consistently enough throughout the year and may struggle to comply with the work requirements year-round. Preparatory work in Kentucky and Arkansas for their work requirement proposals have already required multiple edits and acknowledgement of significant complexity requiring new administrative and data systems which aren't there. And early reports from Arkansas, which began implementing Medicaid work requirements in June of this year, indicate serious challenges ahead. After internal reviews exempted some from work requirements, Arkansas designated about 8,000 beneficiaries needing to comply with work requirements by reporting through an online portal. Only 455 of them did so successfully in the first month. Many of the more than 7,000 of the beneficiaries who did not report work hours were likely working or should be exempt, and with 2 additional months of noncompliance, they'd get locked out of Medicaid until 2019. And now, months later, we know what happened. Arkansas exempted about 2/3 of eligible people from reporting. That left about 20,000 people. Of those, 16,000 didn't report. Only 1,200 people, about 2% of those the requirement hit, reported that they had met requirements in August. Because of this, more than 4,300 people were dropped from Medicaid for failing to meet work requirements. They can't reapply until next year. Advocates make a pretty good argument that the administrative hoops may be just too much for some of these people, even if they're exempt. More expected to lose coverage in the months to come. And let's not forget that it's not clear that all of the proposals include the job training, education, and counseling that were critical to any success for other programs' work requirements. Moreover, the federal guidance inviting states to develop work requirements for Medicaid specifically prohibits using Medicaid funds to pay for those services. But given that Medicaid work requirements are still very new, it's important to acknowledge that we don't know how they're going to perform across the board. We can just guess. But we do know what might go right or wrong, and we should absolutely commit to seeing what does. Here are some questions that really need to be answered. Does a work requirement help meet the mission of the program? What is that mission? How do we measure success? Where adequate employment is not available, what other work-related activities may be available? If program participants lack the skills to obtain employment, would job or skills training be provided? Does the program have the capacity and funding to provide training? What are the administrative costs of developing and maintaining the infrastructure for implementing work requirements? And how do those compare to savings? When individuals receive benefits from multiple programs with work requirements, will one program's requirements take priority over the other? And if so, which one? How will programs track which participants are receiving benefits and their compliance with work requirements? Will these result in people who qualify for benefits losing them? What are the implications for children? And for children specifically with disabilities? Do work requirement policies contribute to disparities across populations rather than solve them? We can answer many of these questions for the programs we've described before, particularly EITC and TANF. The debate over Medicaid work requirements cannot be resolved without answering these questions, and we don't yet have those answers. States probably shouldn't rush forward until we can. Social safety net programs are immensely complicated, and it's going to take a lot of study and thoughtful discussion to reshape them in a way that works. If you're going to try something new, especially with a program like Medicaid that people rely on to literally keep them alive, it's important to make sure you're doing more good than harm.